Thank you, Dave. Thank you very much, Dr. Flanagan, for your introduction. Good morning, everybody. As Dr. Flanagan mentioned, that's our subject today. So the objective of the day today, we'll be talking about erection physiology, different modality, update and management erectile dysfunction, discuss those therapies, mechanisms, and their evidence in managing erectile dysfunction, overview the guideline for these therapies. Starting with erection physiology, most of the time the penis is mediated by sympathetic control, under sympathetic control, mediated by noradrenaline, which keep smooth muscle tonically contracted for placidity. Once there is a stimulation, which is mediated by nitric oxide from the cavernous nerves, induces smooth muscle relaxation and arterial dilatation. Then there will be a latent phase, which there will be blood accumulation within the sinusoids, which compresses the subtonical venous plexus and decreases the venous flow. Then the Thomason's phase, where expansion of the corpora cavernosa and stretching of the tunica albuginea, which compress the emissary veins. Full erection phase, where the intracavernosal pressure reach up to 100 mm mercury with oxygen content increases, reaching up to 90 mm mercury, as blood trapped inside the corpora cavernosa and penile erection occurs. Rigid phase, where the ICP keep increasing and contraction of the ischial cavernous and bulbocavernous muscles, leading to glands engorgement and more rigid erection. Here's a picture of more detailed and more zoom-in physiology over the process, where the nitric oxide coming here from the cavernous nerve or by the parasympathetic nervous system, parasympathetic autonomic, mediated by acetylcholine, which mediates the endothelial also to enhance secretion of nitric oxide. Nitric oxide will then increase the cyclic JMP, which by itself, when it's binding to its protein, will decrease the calcium intercellular level, and therefore will induce smooth muscle relaxation and more blood accumulation. Regenerative therapy. What is regenerative therapy? Regenerative therapy is aimed to restore the structure and the function of the organ, and it's supposed to be as cure rather than managing the symptoms. There's different modality used in erectile dysfunction, the low intensity shockwave therapy, platelets rich plasma, stem cell therapy, and amniotic fluid matrices. Most of the studies that carried on those investigations are using for erectile function evaluation using different questionnaire, but mainly the International Index of Erectile Function, the more apprehensive one, the shorted one with 5 questions, or they would use the MCID, which is the minimal amount of change needed in the erectile function domain to clinically meaningful erection to patients. These were defined as according to baseline of ED severity. So if it's mild, it should be more than 2, moderate should be more than 5, and severe more than 7. The erection hardness score, where the 1 penis is large but not hard, 2 it's hard but not enough for penetration, 3 it's hard and just enough for penetration, number 4 is completely hard and rigid. Low intensity shockwave therapy. What is a shockwave? They defined it as when a wave propagates through a medium at speed faster than the speed of sound, travels through a medium. A shockwave is generated with characteristics rapid raise time and high positive peak pressure. What's that mean? For example, when an airplane travels faster than the sound, what the acoustic wave generated is the shock wave. Here is different type and different characteristics of each machines. We have the electrohydraulic, which is operating by fluid vaporization and cause a shockwave propagation, which appear here in this. Which is appearing well. This machine is the mid-piece ED 1000. Other mechanism is the electromagnetic, where there is magnetic field happen to lead to shockwave propagation, which this one developed by Storrs, Duluth. And the last one is the piezoelectric, where there is mechanical, through a ceramic element, there is some mechanical disturbance which cause the shockwave propagation. And this was the one developed by the Wolf. Those are the one used in the randomized control trial I'll be showing after that. What is the mechanism of action? The proposed mechanism of action of those waves is to cause a microbubble and subsequently cause endothelial microtrauma. What happened? At the level of blood vessels, there will be increasing of some growth factors and nitric oxide synthase, okay, which leads to new angiogenesis and subsequently creating or healing of the arterioles and improve the micro circulation. At the corpora cavernosa level, it will increase the smooth muscles and it will decrease the believed to decrease the collagen, increasing the elastin. At the end, it will cause tissue remodeling and restore the elasticity. At the interstitial tissue level, it will cause some mechanism of increasing some growth factors and some other factors and decreasing other factors, which leads to increase the cell survival and tissue repair. At the nerve level, also, there will be some mechanism of actions as appear here, which cause activation of Schwann cell nerve repair and regeneration, and that would lead to reinnervation. Here also was what is emphasized by the studies and the literature, angiogenesis and proliferation migration of the differentiation in penile tissue and enhance of Schwann cells repair and regrowth. We'll start with the preclinical studies and then we'll proceed to clinical studies. Preclinical study, there's a comparison study include 32 rats had pelvic neurovascular injury. The shockwave group improved their erection function by leading to angiogenesis, tissue restoration, and nerve regeneration. In another study of different modules of the rats caused by erectile dysfunction, caused by diabetes, where they found that after the shockwave, there is an significant increase in endothelial nitric oxide synthase and vascular endothelial growth factors. Okay. Also, other studies showed other increasing in the ICP, intercavernous pressure and mean arterial pressure ratio, and increase in smooth muscle. The thing is, with those preclinical studies, the damage or the trauma to the neurovascular or the causing of ED happened acutely and was treated at the same time. It's different than what happened in actual life, where most of the patients clinically will suffer from erectile dysfunction for a period of time, and it's as chronic manifestation. Those those studies found to have, unfortunately, different protocols ranging between 200 to 3,000 shock waves. Okay, and different machine were used. So those are the downsides or the limitation involving in those studies. Clinical studies. There is the single arm studies, non-placebo control, randomized non-placebo control RCDs. So those studies, it shows some improvement. However, different questionnaire were used, and which is make it difficult to compare between those studies. Different devices and protocol, and follow-up was generally quite short. Here we can see in the schedule that some of them are using the EHS, some of them are using, depending on IIF 5, and the other is the IIF MC ID factor. But with those, the flaw or the limitation with these studies, and even the randomized control trials, is where do we stand? What's the shockwave in different scenario? What's the shockwave is needed for angiogenesis, for the blood vessels? What's the shockwave is needed for reproducing or regenerating the nerves? Is there any limits? If there is any limits that's beyond it, there will be developing some side effects, or below that one will be inconclusive. So we still in the area, that's what the literature showed, we still in a vague and a gray area regarding that one. Randomized control trials. Here's a trial done by Serene for the PDE5 inhibitors responders. He used, the protocol was 12 sessions over 2 weeks, then a break, then 2 weeks. So every 3 weeks, sorry, and 2 sessions per week, total of 1,500 shock per session. He randomized 60 patients of treatment versus 17 protocol. Duration was 12 months. Results, he found that the IIEF 8.7 change from the baseline, and 83% of the patient reported an erection hardness more than equal or more than 3. Limitation with this study, he has the bias, where there was a high risk of bias with significant dropout of 47% in treatment group and 58 or close to 60% in the placebo group. In general, the dropout of more than 20% of a study will start to raise the issue of bias. Other study done by Yi, he examined 30 patients who received the shockwave, and 28 was the placebo. He used the same protocol as the previous study, as 12 session. Each session is 1,500 shockwave using the hydroelectric. Duration of the study was 1 month. Result, the IAF improvement was with the shockwave 7.6 versus 5.6 of the sham group. The EHS more than 3. It's as at the 13 week of the study, 57 versus 9%. The limitation of that one, unfortunately, the study was not statistically significant. The number was not statistically significant. Other thing, it's based on the power calculation of this study, 70 patients were needed to be enrolled. However, here we have just only 58 patients. Other thing is at the study manuscript that they used the control group. They used the same probe, or the same probe, and they were to make the same noise. However, they put the energy at 0, so that's also will raise some suspicions of bias. Other study by Olson to assess the shockwave therapy. Also here, the PD5 inhibitor responders, 50 for treatment group versus 51 the sham. The success threshold primarily set as a change in the International Index of Erectile Function questionnaire. Secondary outcome is the EHS more than 3 to 4, more than 3. He used a different protocol here and a different machine. He used the one session weekly for 5 weeks. He used the daily, which is the electromagnetic in mechanism by stars, and the total were 3,000 impulses. Results were found more than 5 points. The treatment group, 34% of the treatment group reached above 5 points versus 22 with non-statistically significant. However, the erection hardness in the treatment group were 57, surprisingly, versus 9 in the sham group. Patients after the first session, after 10 weeks, the sham group will given access to the shockwave therapy. However, when compared at 24 weeks, the erection hardness, 19% were seen in the treatment group versus 23% in active placebo group, and IIEF more than 5 points, 12 versus 15. Here we can see some inconsistency in this study, where the EHS is significant by 57%, hardness 3 and 4. However, the EF is only 34%, and even it's not statistically significant. That's one of the limitation. The other limitation is that we can see that with time, the first group or the treatment group, that the IF were 34% and dropped down to 12% in 6 months, and the hardness from 57 dropped down to 19%. Here's the other randomized controlled trial was done by Vardy, one of the first studies who started the shockwave therapy for erectile dysfunction, where he used 40 patients versus 20 the sham group. All were PD5 inhibitor responders. He used the same protocol with the same machine, the hydroelectric 12-session protocol. However, the duration of the study was 1 month after the treatment. The results were the IEFs increased 6.7 point versus 3 point change from the baseline, and 78% increases in EHS above 3 versus 3% in the sham group. The study limitation showed short follow-up within a month, low population number. It found that the shockwave group had a younger mean age comparing to the sham group, which is affecting the erectile dysfunction as the age is predictor value. Other study done by Kitri also. These study were conducted for patients where non-responder to PD5 inhibitor, where he examined 37 versus 18 sham. The outcome IIEF greater than 5 point and EHS equal or more than 3. 12 session given with hydroelectric result, the IIEF median increased by 5 in the treatment group. However, the sham group, no change. The treatment group, the erection hardness scale reached to 3 in 54% versus none in sham group. And he found that the Shockwave patient was able to convert to PDE5 responder to none to convert to start to respond to dose medication. The limitation for this study, it was short follow-up, and the population were small populations. Other study done by Foyke, where he examined 58 active group versus 60 sham. This studies included PDE5 inhibitor responders, PDE5 inhibitor non-responder, and naive to the treatment. He used here another machine and another different protocol, where he gives 5 sessions, 5 weeks, and during this 5 weeks, each session a week, the patient will receive 600 shockwave. And as we can see here, they would have the shockwave for 5 weeks, then break for 4 weeks, then the shockwave for another 5 weeks, then a break. And he calculated the IIF and the EHS at the baseline after 5 weeks and after the second 5 weeks of treatment. He found that for the sham group at the baseline, it was 11.5, then increased to 13, then after receiving a 5 weeks of shocks wave therapy, the IIF were 12.6. The active group 10.9, then after first treatment session 13.1, then 11.8. Success rate between the two groups were comparable in IIF, and for erection hardness scale above or equal to 3, both the sham group was 6.7 and the active group was 3.5. And looking at the subgroup, the responders, the mean IIF, it's similar or close to the results of the whole group, where the sham group 12.7, then decreased to 10.9 and stays at 10.9. Active at 12.2, then increased to 13.5, then after the second session or second treatment, reached to 12. Looking at the overall satisfaction with the treatment, both group was non-satisfied. The both group were satisfied just only by 50%. He concluded that there is no clinically relevant effect of shockwave on erectile dysfunction treatment. Here, by the most of the study, the randomized controlled trial studies done in the present in the literature, were examined by the Canadian Urology Association members, and they found that most of those, they would have high risk of bias and high risk of some concern belonging to these studies. Here, just like we can see that with Srini, he got bias in selection, he got bias selection, bias in reporting, and some concerns in other modality. Verdi, he has bias in reporting also, and some concern regarding selection. What's the cost? Here is by across the United States, the overall or the average cost, it's about $500 per session, and almost $3,500 per the whole treatment course. What would be the guideline stand or state regarding these therapies. AUA, they stated that for men with ED, low intensity extracorporeal shockwave therapy should be considered as investigational, as a conditional recommendation, evidence level C. European Urology Association use low intensity shockwave treatment with or without PDE5 inhibitors, patient with mild vasculogenic erectile dysfunction, or as alternative to first line therapy in well-informed patient who don't wish or are not suitable for oral vasoactive therapy or desired curable option. Recommendation is weak, using shockwave therapy with or without PDE5 inhibitor for poor response to those therapy, also using shockwaves. So in overall, the European Urology Association voted as a weak recommendation. Canadian Urology Association stated that conditionally recommend against shockwave therapy as treatment because, and also the panel clarified that those studies has a different protocol, different shockwave machine, different energy levels, duration of the treatment, various sham treatment, inconsistent follow-up, varying metrics, and put those RCT in significant heterogeneity. PRP is the platelet-rich plasma, or what they call now is the P shot, is where we take a blood. They would centrifuge in 2 times. First centrifugation, the red blood cells and white blood cells will be discarded. The plasma and platelets will stay as it's appear here. Then they would do another centrifugation, second span, and concentrated platelets will be here. Then it will be injected, aiming for therapy. As a background for platelets are rich with growth factors that promotes recovery of the damaged tissue. Also has the ability to regenerate regenerative function and recruit stem cell modulation and modulation of inflammatory response. In animal studies, they found that it's decreased the apoptotic markers. Here are most of the growth factors, okay, that is available in the PRP, which is the platelet-derived growth factor, which enhances cell growth during generation of blood vessels and collagen production. We have also the vascular endothelial growth factor, which is also enhance endothelial cells, including other factors that help in regeneration, stem cell modulation, and inflammatory cells remodulation. There is some limitation with PRP in general. Limitation, they found in the literature that significant variation of PRP content have been reported within an individual patient over 2 weeks time period. Even if he's the same individual taking the same blood, okay, there will be variation in the platelets within a 2 weeks period. On the level of the growth factors delivered will be the bioavailability will be depend on the individual patient characteristics, platelet concentration, level of leukocyte and red blood cells, and methods of activation. Also have been found that is it should be exceeded 3 to 7-fold from the physiological situation, more than millions, to be show some therapeutic effect. PRP in different specialty. PRP were examined and used in REG in orthopedic. There's a systemic review of 16 randomized controlled trial showed that PRP is effective in treatment tendinopathy. However, in a systemic review of 105 studies, they take the almost 11 studies that have the least bias, and they found that although with those heterogeneity was encountered, there was Majority of the study did not provide sufficient information to allow the protocol to be re-examined again. In cardiac, a study showed that it decreased the infection rate from 2% to 0.6%. And also they showed in the same study that the readmission decreased by less than 1%. And dermatology used in alopecia areata, however, their dependency on that one are based on case reports and small study. On the preclinical trial, there is one trial where they crushed the cavernous nerve. 8 rats got the plasma PRP and 8 to 9. After 8 weeks of injection, there is a significant recovery of erectile function, increased in ICP, and histologically they found that there is significant preservation of myelinated axons of cranial nerve and reduced in apoptotic index. Other study in follow-up in 3 months showed the same results. Limitation of this preclinical study, the sample size was, both the study were small. Both the study acknowledge that the effect may vary depend on the dose, preparation, and administration of these of the plasma, and furthermore studies needed. In general, we are here. What's fascinating? In general, we are injecting a high concentrated blood, which is a platelet, into a big vein, into a penis, which is a big vein, which there's a lot of blood coming in and a lot of blood coming out. And comparing that success to success of like a joint or hair follicle will be fundamentally, or seems to be, a bit problematic, because that one is a big vein, and the other organ like a joint or hair follicle is very small, significantly little blood vessels are reaching those areas. Clinical study, there's a study involved 17 patients, only 4 got erectile dysfunction, the other were Peyronie's disease or mixed. Okay, they got between 1 to 8 injection. They found that IIEF improved by 4 points. However, the study was low number, no placebo. There was no mention of pre-injection IIEF, and no follow-up was done. Other studies showed the same result. They measured the IIEF before and after. Before was 15, and after was close to 20. However, it was low number, low placebo group, and no follow-up, and that one was just only an abstract. The paper did not see the light. Here we go with the randomized control trial. Okay, there is a trial here done by Polius where he examined 30 patients, have a treatment and placebo with 30. He puts the PRP as, they received 2 sessions of PRP, each session 10 ml, and with 1 month apart. He put the outcome to be as IIEF of 2 or more points as the Rosen, 2 or more points in the mild or mild to moderate, or 5%, 5 more points increase in patients with moderate erectile dysfunction. Mean IIEF were 19 or 20 plus minus 3. The results were domain, the IIEF score improved by 2.7, and 2.7 at 1 month, 2.8 at 3 months, 3.9 at 6 months. There is, in this study, there is a dropout about 16% in the treatment group. The treatment it has low population number. And there is another study which contradicts those results, just recently published by Masses and Ramazani group, where he examined almost the same number, same protocol, and he used the only difference, those people the previous study used 10 ml, Ramazani group, they used 5 ml. Okay, however, in Ramazani study, they found no difference in the group, in the IIF, and even in the Doppler parameter, as it's told also by the here in the charts. PRP provider globally, there is almost 683 provider worldwide, 21 in Canada. The cost range between 1,500 to 2,200 per procedure. Where does the guideline stand? The AUA guideline stated for men with erectile dysfunction, platelet-rich plasma, therapy should be considered as experimental. The Canadian Urology Association mentioned that because of the limited number of peer-reviewed human studies to support this experimental regenerative therapy, so they vote against it, or to still as experimental. The European Urology Association were more directed by mentioning if there do not use platelet-rich plasma to treat erectile dysfunction outside convenience of clinical trial. Other modality, which is the stem cell. Stem cell has the ability to regenerate, has the ability to to regenerate, has the potency of angiogenic, anti-fibrotic, and anti-apoptotic. In the literature, it was classified as an adult-derived stem cell, embryonic stem cell, induced pluripotent and amniotic fluid stem cells. The mainly or the most used one in the literature is the adult-derived because of the many factors, including ethical factors, and they found that the adult-derived stem cell are less oncogenic, less genetic instability versus other stem cells. And most of the examined or used are the adipose-derived stem cell because it found in vitro that it has the ability to regenerate vascular cells and nerve cells. Preclinical studies. There's a meta-analysis of 20 studies, including almost 250 rats. They used the adipose tissue-derived stem cell, and they found that it can recover erectile function of different rat models. It increases the ICP map ratio. It's increasing the cyclic GMP, small muscle cells, decreasing the collagen. And also they found in those studies that adding growth factors with it accelerates the recovery in erectile dysfunction in those rats. Clinical study, here's a study done by Har, where he examined phase 1 clinical trial, where he examined 17 post-radical prostatectomy patients, 11 continent and 6 incontinent with failed PD-5 inhibitor and intracorporeal injection therapy. The radical prostatectomy performed 5 to 18 months and the duration was 6 months after the injection. They used the adipose-derived regenerative cells. He found that the 8 out of 11, the IIF at the first month showed no change, equal to 7. At 3 months, increased to 17. And at 6 months, surprisingly, it increased to 11, and at 6 months increased to 17. EHS was 1, and at 6 months increased to 3, from barely hard to hard for penetration. There was no serious adverse events. He suggests that it's promising. Here are the limitation that we can see in this study. The erectile function in the literature, it is at its peak after the radical prostatectomy within 3 months. It's within 3 months, it's almost the erectile function is completely gone, as per in the literature. And the recovery would take 2 years. And to go back, very rare is to go back to the baseline, even after 2 years, to go back to the baseline. It's very rare. And here that we can see also those patients failed the PDE5 inhibitor and failed the prostaglandin injection. And here we can see a patient just only within 5 months of trying those and failed and get benefit from the stem cells within 5 months. Those are what I'm thinking as the limitation of this study or the bias. Here's other study, phase 1 and phase 2 trial of post radical prostatectomy. They uses with PDE5 inhibitor. In phase 1, there was 12 patients. They give them 4 escalating doses. In phase 2, 6 patients is only 1 dose received. Here's another different, other than adipose tissue. Here they use the bone marrow mononuclear cells. For stage 2, after 6 months, the IIF intercourse satisfaction increased from 2.2 to 7.8, and the erection function increased from 3.7 to 18. The EHS increased from 1.8 to 3 within a 6 months period. However, for stage 1, when they followed them up, they found that at 6 months, that the therapy, the IIF, it's decreasing after it's peaked from 18.1 and start to decrease to 15 plus minus 8. And there is no serious adverse effect were noted. Here that we can see that the IEF is decreasing or declining with further follow-up, which is unfortunately, it's not fulfill the regenerative therapy definition as to be a cure rather than symptomatic management. Other study by Levi, he examined 8. They received another method or another type of stem cells, which is the placental matrix, and he followed them up of 6 weeks, 3 months, and 6 months. Here the studies are he used more objective in his study. Surprisingly, the peak systolic velocity at the baselines was 26.5, and at the tripled at the 6 months were 73.9. The IIF was not significantly not statistically significant. And in his study at 6 weeks, 2 with failed oral therapy had ability to sustain erection with the therapy. At 3 months, 1 patient achieved erection by his own. Here it is, from baseline of the 26, 6 months tripled with inconsistency with IIF, which is not significantly, not statistically significant. That also will raise the issue of bias in this study. In general, for the stem cells, regarding the literature, in the literature reviews of most of the study in the stem cell, and all of them for the erectile dysfunction, the population is really reaching up to 70. And in those studies, there is significant heterogeneity in the blinding, in the protocol, in the using different kind of stem cells. And also, if you look at those studies, they mentioned it was just only mentioned regarding the safety and the efficacy. So the main object or the main outcome for those studies were the safety than the outcome with IIF. Whereas the guideline stands here, the AUA stated that stem cell should be intracavernosal stem cell therapy should be considered investigational. the Canadian Urology Association 2021, there have been several small human trials evaluating stem cell therapy for treating erectile dysfunction, but there is significant variability between protocol, inadequate adverse event reporting, and lack of follow-up, long-term follow-up. Other regenerative modality is the dehydrated human amniotic membrane, where the biologically it is derived from human placenta, and it showed, as based on the literature, it shows it has some regenerative characteristics. It's preventing fibrosis. It's causing new angiogenesis. In other studies, it showed that it's healing ulcers and burn injuries, and it recruits stem cells. Used in urological, there are just only 3 studies mentioned for this treatment modality, where during the robotic prostatectomy, the nerve sparing, the nerves were wrapped by the amniotic sheath, and after that, those studies measure the IIF or the EHS, or measure the potency for their patients. Here, versus study done 2018, or one of the study done 2018, they were examined all patients that underwent nerve-sparing, bilateral nerve-sparing, robotic assisted laparoscopic prostatectomy, 700 versus 700 control. Potency was defined as ability to have satisfactory penetrative more than 50% of the time, the shim more than 17. They found the results, the potency recovery was significantly less, the time to potency was significantly less, which is after 2 months of the robotic assist, after 2 months of the prostatectomy, they reached their potency according to their outcome, and comparing to 3 months or more with the treatment group, and they found that the treatment has significantly higher percentage of patients becoming potent compared to the control. Here in the schedule that we can see by the quarter year, how many patients they advanced to have to become more potent. Here we can see the number are fairly comparable, even at the end of the year, where the 87% had their potency according to their definition of potency, and 93% of the treatment group. The patients on the treatment group were on daily tadalafil plus intracorporeal therapy, and also here we can see that all the numbers are almost comparable for the whole year. Other study examined 58 patients who underwent robotic assisted laparoscopy and 58 control. The ability, their potency definition is ability to achieve and maintain erection with or without PD5 inhibitor. They found that after 8 weeks, only 8 weeks, 65.5 of those patients regained their potency, and 51 of the control have their potency. Placement of that one, meantime potency treatment were 1.3 months versus almost 1 month versus 3 months. And postoperative shim score were higher than in the treatment group comparing to the sham group. However, in this study, it was an observational study with a retrospective collection, which raised a bias of recall. When I looked at the manuscript of this study, there was no mention of patient data, no mention their mean age, no mentioning of the comorbidities, anything. There is also no statistics were mentioned before and after for the shim questionnaire. And also regarding the follow-up period, no mention there's just only this graph would show a follow-up period of 3 months, which raise a high probability of a bias in this study. AUA guideline for this limited human study have applied this graph during robotic assisted radical prostatectomy with promising clinical outcome of expedited recovery in erectile function. The long-term efficacy, side effect, and oncological consequences of these grafts are unknown at this time and require future study. Thank you.